George Madison, George Washington, and she is an FNP, and she got her PhD from Emory and her postdoc from UW, and that is where she's now teaching as a faculty member. And she's going to introduce herself a little better than I did, but I'm very pleased to show you one of Widener's finest. This could be you. Frank.
Thank you so much. I could not turn down an opportunity to talk to you because Widener is my alma mater. I'm an alum. I had a wonderful experience at Widener. I was in the honors program actually back then. I graduated valedictorian of the nursing program. I won the President's Award. I got the Spirit Award. So I think Widener helped me blossom into who I am today. So it was more like that first step into my career path. So let's talk a little bit about it. As she said, those are my education highlights. But it wasn't until, and we'll talk about this kind of leading to how I got to my research interest in a sense. So Widener University was actually very interested in HIV/AIDS. I was doing a lot of work in promoting, and I was a resident assistant in Kapelski and also in Ventnor Hall. And I did a lot of educational units or educational talks to my fellow or my peers about HIV/AIDS. I was trained by some type of course I took in Chester for a Saturday. Got kind of educator certified. And then took that back to Widener. I was teaching, in all the dorms, in my spare time. So I did a lot of work with HIV/AIDS. When I came out of Widener, I was so excited. I had to take NCLEX by paper. It was not on the computer yet. Waited for my results. And my first job was at George Washington University Hospital in Washington, D.C., and I worked on an HIV/AIDS / med surg floor, because that's what we're told to do, get med surg experience. And my passion was with the HIV/AIDS patients, but back then in the early 90s, and you remember that time, that was when the cocktail drugs were just coming out. So we had pills that did not have AZT on it, it had a number. So the drugs were coming from the NIH trials, and it was the 3 cocktail meds, and we were in a lot of patients that were very young and very sick, and it was very eye-opening for a new nurse, right? So that was my first job, and I just was so passionate about being a nurse and wondering, is this what I wanted to do? I always knew I wanted to go back to school, so I got, the program is actually George Mason University, that's where you get your MN, and then George Washington, where you get your FMP. You're kind of in classes with second-year med students. So knowing that I couldn't cure HIV/AIDS, but I always wanted to kind of work and kind of teach and do more research, I did go back to school and get my MSN FMP. And I started to realize, I can make, what kind of difference can I make? I burned out a little bit on the med surg floor because watching young 25-year-old, 27-year-old homosexual men die was pretty eye-opening and pretty depressing for a new nurse. And there was a bunch of us who kind of needed extra counseling just to kind of get into work. So I moved over to the ICU, went to school, just like everyone else, juggled school and working at the same time. Came out and started working as an FMP. Did some work with teen health clinics, was a youthful, had a very youthful provider panel. My panel seemed to be young. I just was gravitating towards this, young adult or older teen panel, and I decided, what am I going to, is this where I want to go? I think I actually want to go back to school. I think I want to get, further in my career. I also noticed that some of the teenagers that were coming in heavier. So, not being very active and eating a lot of, unhealthy foods. And I was starting to get worried about this obesity epidemic. So this is, in the 2000s, thinking, what's going on here with our younger adults? They're starting to have hypertension. at such a young age, what's going on? So I decided, you know what, I'm gonna go out and get my PhD. So went to Emory University, walking in with this idea for dissertation on obesity. Well, you take one search on PubMed and you realize that obesity, there's, 46,000 articles, at the time it was probably 20,000, but 20,000 articles about obesity. How do you hone that down to a dissertation to make a difference? While I was in Emory, I had a advisor, Kathy Parker, who I think was a dean at Rochester for a few years, but was a sleep researcher and came back from a trip to Philadelphia. It was like a sleep conference, and it was in 2005. And she said, with obesity, what is the so what? What are you going to do with obesity? We had to kind of figure out a theory, and I was kind of focusing on social cognitive theory. I just wasn't sure. She came back with the idea that when she went to the sleep meeting, that there was this novel idea about the inverse relationship between BMI and total sleep time. Mm-hmm. It was the first time it was mentioned at a professional organizational meeting. It was the first time that some of this work was being presented by Eve Van Cauter, Karen Spiegel's work on and some of the larger and Haynes like epidemiological studies on adults looking at that inverse relationship. And it was kind of like, well, that has not been done in the pediatric population, let alone adolescents. I've always loved adolescents. I always volunteered to be, when I was in my FMP program, always wanted to be in the STD clinic, always wanted to be on that teen van, parked out in Northern Virginia, seeing teenagers. I just always was gravitating to this population, and I can never really sure why I always gravitated to them. Was it because of my own teen angst that I was going from, coming from a single parent? I was the first one to go to college. Maybe that's what, went through a little rough patch. That's maybe where I was coming from. Or was it because I could build a rapport very quickly with teenage? I've always had that knack to talk to teens really on somewhat their level, but able to build trust really quickly, and their parents as well. I knew I would always work with teens in my life. So, getting back to my PhD at Emory, I did a review of the literature, found out there was really nothing on this in adolescents. Applied for an NRSA, which is like a T32, which is a grant to give you some money to do your dissertation, and it was funded. It had a great score. It was about adolescent sleep and obesity. So let's just talk about adolescent obesity, and we'll talk about adolescent sleep. We know, and I know many of you know this already, so some of this might be, I know this already, but let me just remind you that children are heavier than ever before, and minority adolescents are disproportionately affected. And I want you to remember that because, and I saw it firsthand, because when I did my PhD at Emory, that's in the Atlanta area, so those kids were, at least half of them were overweight. Any sample that I would kind of reach out to, half of the kids were overweight or obese. They were eating fast food on their way to school and on their way back from school. It was an interesting dynamic, and I just was always concerned, and that's just almost like regionally. We know that the states down in the southeast of the United States are just so heavier than like, say, Seattle. We're actually pretty healthy up there. Factors that determine a positive energy balance are still not completely understood. Numerous health conditions, such as impaired glucose and hypertension, glucose intolerance, have always been typically associated with adult obesity, are now threatening adolescents. And then current approaches of losing and maintaining body weight are ineffectual and contribute to cyclic effects of failure. I see that firsthand. So one of my roles right now at the University of Washington is I'm part of a training grant called ALEA grant, which is Leadership in Education, Adolescent Health. There are 7 of these in the nation. It focuses on adolescent health, and it trains fellows. It's an interdisciplinary, so it's nursing, social work, nutrition, psychology, and medicine sitting at the same table, listening to seminars and talking about adolescent health and how we can improve it. And part of that is we talk about some of these, they have actually a weight loss program there in Seattle, and we're just seeing how it works, how it's not working, what will work. You know, it's just sometimes with obesity and any of the intervention that you try, it's so difficult to maintain or to change. They have to be ready to change. They have to be able to maintain that. You know, the BMI might come down for 3 months, but then it pops, you know. And they're also growing. Adolescence is a period of growth, not just socially and psychosocially, but also biologically. So, you know, but it's quite a challenge. And then on the other hand, we have adolescent sleep. So that sleep bug was started, or that passion for sleep started with Dr. Parker when I was at Emory. And I just needed to learn more about it. I did not know about sleep other than that, you know, I was not getting enough. I always wanted more. I always slept in on the weekends, you know. But I needed to kind of give myself a primer. There's like one textbook on sleep, you know, like The Principles by Dr. Krieger, I think his name. You know, there's no course on sleep. You know, there was maybe a lecture, but there was nothing on sleep. So I had to kind of go back to the literature and read, and you know, and then you read a lot by Jody Mindell, and you read like, you know, what Carol Landis did, and University of Washington has a lot of that sleep literature that came out of it. So that's when UW started popping in my head. But adolescents sleep less today than just a few decades ago, possibly due to technology. It can also be for, you know, them going through puberty and other biological changes, but I think they're always on, and I think there's a lot of technology that's still in their bedroom. Maybe it's not a TV, but it's an iPad or their smartphone, and it's keeping them up at night. Research suggests that both too much and too little sleep can lead to obesity, and the reasons are far from clear. Is it because they're sleeping too little? This is my thought. They're sleeping too little, and it might be disrupting their neuroendocrine release of leptin and ghrelin, or dysfunctioning their insulin and glucose during the day. Or is it because they're sleeping too much because they're depressed? You know, like there's all these things that are going on. It's hard to do research into obesity because there is so many variables you need to control. And we'll talk about that when we get into my methods. You'll see why there's so many surveys I have to give them. Oh, and then just sleep is exciting. So sleep has come a long way. It wasn't so exciting. I think it's coming around. If not, you see it pop up in the lay literature. You see people talk about it on Good Morning America. You know, sleep, we need more sleep. There's not enough sleep. There's always some like better ways to sleep, apps that you can use to sleep better. So you see it bubble up, but the research itself, there's still more to do. So back to I've always used these two frameworks. I won't just say it's for my dissertation, but if you ever plan to do research on sleep, this is one you need to know. It's called the Process S and Process C. And if you look at Process C, that's your circadian rhythm, up and down, up and down. Process S is homeostatic. So during the day, you're building this urge to sleep. So all day, unless you take a nap, then you expunge it. But all day, we've been waiting to go lay down in our bed. So it climbs, and here we are, you know, it's getting 9, so we're about here, right? So that's process S. So if you're ever interested in sleep, that's a physiological conceptual framework or model that you could use for your work. This, though, is something that, it's a little blurry, but this is what I did my dissertation on and what I do most of my research on, is talking about sleep deprivation, how it leads to endocrine and hormonal changes, like changes in leptin and ghrelin, changes in your metabolism, changes in insulin and glucose that then increase hunger, increase your opportunity to eat, alters your metabolism, increases your fatigue, which can cause eating more, reducing your energy expenditure, leading to obesity. Very neuroendocrine, like this leads to that. I'm always bumped up against the, well, where's the proof of that? Or what if it's the other way around? What if it's because, you know, they're eating too much, then they're not, you know, there's always skeptics, but this model is actually seen more and more in the literature because we're starting to figure out some of these pieces, especially in adults, that if we sleep deprive them like 4 hours for 4 days, and then put them on an extended sleep, like 8 to 12 hours for 4 days, you see those, in 4 days, you see changes in their appetite hormones. Leptin and ghrelin control your hunger and your satiety, or that feeling of feeling full. So leptin comes from your, like, all over your body from your fat stores, but ghrelin is kind of triggered by your stomach, goes up to your brain. So just very fascinating. So I kind of use both these models in my work. Just briefly, this was back when I was at Emory doing my dissertation. I called it the teen sleep study. It was to examine those associations with total sleep time, or sleeping at night, hunger, satiety, food craving, sleepiness, fatigue, food intake, physical activity, and BMI in a sample. So many variables, right? Because if you remember that, the schematic I just showed you, there was so much going on. It was descriptive and cross-sectional. It was a convenience sample in the metro Atlanta area and the Emory community. You know, you always have professors' daughters or sons who want to earn, a little bit of money. Collected October to April, and I had 87 students from DeKalb County, DeKalb High School. So this is the first time I did an IRB through a high school. So that was like a learning process in itself. But I gave them demographic surveys and clinical data surveys and I measured their BMI. So I carried around the stadiometer, which is actually like a plastic thing that you can measure their height with, and then and have them on a digital scale. Pubertal status, not by Tanner staging, but just giving them a survey, and just if they were depressive or not. I had them keep a sleep diary. So I'm telling you things of how I used to measure, and then we'll compare this to what I do now, and you'll see there is a big difference with the measurements. Just asking them about how physically active they are, measured just how fatigued they were on a daily basis, and then gave them a school sleep habit survey, which is from Mary Carskadden. Mary Carskadden is up at Brown University, and it was one of the, she's an expert in the field. She's probably one of the only ones who really knows and has been there since her years at Stanford in adolescent sleep. And I emailed her and asked her if she would be on my dissertation committee, and she said yes. It's a good thing and a bad thing, because I had to convince her that there was such an association between BMI and total sleep time. I had to convince her, and wouldn't you know it, I just checked on NIH Reporter, and guess what kind of work she's doing now? Yeah, she's looking at sleep and like food intake and like different types of food. So I want to say that I was part of that, because I used to defend in my dissertation, like, no, there is some relationship, it's just different. I also learned how to do 24-hour diet recalls just one day, but if you ever sat down, it's even hard for us to look back and say, what did you eat yesterday? Tell me. And so for a teenager, even harder, and it was usually one day, so sometimes I would get a really weird day. So I had to change how I measured that as well, but we'll get to that in just a few slides. So just briefly, the conclusions from that dissertation was similar to previous studies. These adolescents did not obtain the recommended amount of nocturnal sleep. A lot of them reported excessive daytime sleepiness, meaning that, and they were very honest, they would fall asleep in the morning, like during Spanish class. So they were just falling asleep when they got to school. Race and gender were significant predictors of hunger, satiety, and caloric intake and food cravings. I wrote these two up in a manuscript. And daytime sleep or napping was a significant predictor of certain food cravings and caloric intake. So the one thing I didn't find was that inverse relationship. So I wasn't able to, my hypothesis, what I really was doing my dissertation about, but I learned a lot in the sense of, like, there is some relationship, there's something going on, but is it with the napping, is it with the food cravings, is it because they're going through puberty, or is it because of how I measured things? Like, asking them one day what did you eat, might have not capture really the caloric intake of an average teen, or even their sleep. I asked them to keep a diary, and that's how you can do it for for no budget. You can ask them to fill out a diary, but we do know teenagers that they may wait till the last minute and fill it in all of this, 5 minutes before they're going to eat. So we'll see. And then failure to control for some of those unidentified confounding variables like SES, or did I capture depression enough? Like those kind of questions. But I did know that we needed to bring sleep more to the clinician, meaning that the clinicians need to be aware of how important sleep is. I know at UW and in Seattle we talk about it all the time, like it's just something you need to ask and something you need to kind of be aware of, and are you sleeping, and how much do you sleep, and then also parents and adolescents need information regarding age-appropriate sleep requirements. So then the National Sleep Foundation is the website that I usually direct people to go to, and it gives them recommended times. For a teenager, it should be 8.5 to 9.25 hours per night. For my dissertation and for the next study I'm going to show you, it was about 7.5. So they're definitely not getting enough sleep. A couple years ago, when I was at UW, I applied for the Robert Wood Johnson Foundation Nurse Faculty Scholarship and got it. And they've transitioned. They're not doing this program per se anymore, but they're doing other type of cohort leadership studies where they give you funding to also meet with them and talk about leadership skills and education, how to be future deans of America. But they also give you money for research. So again, here I am talking about the effects of sleep deprivation on body composition, diet, food cravings, activity, metabolic and endocrine function. So you can hear that my things are refined a little bit more. And stress in a group of adolescents, because I never measured stress before. Maybe that's one of those variables that I need to control for statistically. So this was 40 adolescents recruited from Seattle. Again, they're a little bit healthier than the Atlanta bunch. Had a Facebook page. It was 3 visits over 9 months. They did a bunch of stuff for me. They came in for a fasting blood specimen. They got into a bod pod, and I'll show you a picture of a bod pod in a minute. It measures their body composition in 10 minutes. They have them at CrossFits in Seattle. You strip down to like a swimsuit and a swim cap, and you shove the teen into it and close the door. And in 10 minutes, you can accurately measure their percent body fat. Instead of doing the calipers on the arm now, I know a lot of people do waist circumference, and waist circumference I'm not opposed to. I think actually they're talking about waist circumference more so than BMI in some aspects, but I wanted to know their percent body fat. So that's what the bod pod, and we have one in school nursing at UW. Pre and postprandial blood specimens, study questionnaires, food recalls, again that sleep diary, and they wore an actigraph. This is what an actigraph looks like. This is the spectrum, actigraph spectrum. It measures not only their sleep, it also measures light. So these 2 little buttons at the top are measuring lux that are coming in during the day. And the reason I wanted to do that, because it goes back to that question of, is technology keeping these kids up? I wanted to see how much blue light is coming in and keeping the kids awake. So, has anyone worn an actigraph? Does anyone wear like Jawbone or Fitbit? So Jawbone, so there's other ones, Fitbit, Jawbone. There's several personal devices that you can wear. Seattle, it feels like, I think like you wear one, everyone wears one, but you wear it and it counts your steps. It can calculate like lap or miles that you've walked. Sometimes it can do kilocalories too.
Yes, it's additional apps.
Yeah. So, and Jawbone can also do how many hours you sleep if you program.
And
So,
whether it's light sleep or heavy sleep.
This is the original, if you want to look at it as like Jawbone, but this costs like $1,500. It's for research and it's validated. And we use it, like Karen Thomas, who's at UW, used to put them on babies' ankles. Carol Landis used to put it on women who were going through menopause, or Nancy Fugate Woods put it on women who were going through menopause. Carol Landis put it on women or kids who had JIA. You know, like, we have used them since the 70s. So this is a valid piece of equipment. Expensive, but it gives me a lot of kids. So you find a non-dominant wrist, and the teens would wear it, and they thought it was cool in some regards because their friends or their peers would ask them, and they thought that they were like on what do you call that? Like in-home detention, you know, or in-school detention. So the teens thought that was cool, and I know, it's so sad. And then salivary cortisol levels. So this is the first time we started getting into cortisol, and they just had to suck on a salivette to measure their cortisol. Cortisol starts out low in the morning, starts out low when you wake up and climbs during the morning. But if you're sleep deprived or under a lot of stress, you can see differentiations in the wave of waking up. So I wanted to look at all of those variables because all of them are related to teen sleep and obesity. This was just a study program. We'll go through it, but it was quite comprehensive. And that's probably the downfall, is that there was a lot going on. It's hard to get a hold of a teen because they're busy, just like you guys are at Widener. They're just as busy with lacrosse and soccer and schoolwork, and so it was hard sometimes to get them. And I did a lot of my research on the weekends. So I was drawing their blood because they didn't want to miss school, and their parents didn't want them to miss school, so I came in on the weekends with them fasting, and they would be so hungry and angry with me. But this was a quote from Lori, one of my, I sleep well, I just don't sleep enough. And I heard that a lot. They feel like and then looking at their agiograph, they fall asleep really quickly, like with under 5 minutes. But it's probably because they're so sleep deprived that they can fall asleep. And typically teenagers don't wake up unless they're getting texted, a text or vibration, or something is dinging them to wake up. That's kind of where my future work is going. But for the most part, teenagers, without the text without their smartphone in their room, they will sleep. They're not waking up to go potty. They're not like waking up because they're snoring, unless they have OSA, which is a small percentage of obstructive sleep apnea. But for the most part, they sleep well. They're healthy. So again, this is just some results from that RWJ study. They're about 14. It was from 13 to 17-year-olds. So I pulled away from puberty a little bit, just so I could kind of step away from puberty and not have that as a confounding factor. 50% of them were female, the other were male. Race 62.5 white. So Seattle, we are not a diverse group in Seattle. So that kind of actually represents the area that I'm living. Number of electronics, I kind of create, there's maybe one survey that talks about sedentary behavior, but I kind of had to add the question of how many electronics do you have and list them. And on average, every kid had something, but on average it was like 2.5, 2.4. So it's usually like a smartphone and an iPad and a laptop, something of that nature. And then the TVs in the bedroom mode declined. And that makes sense because now we're not really watching TV per se. We're watching things on Hulu or watching things on Netflix. So again, they were sleeping even less than my previous work. So now on a weeknight, they're sleeping 6.96 hours. On a weekend night, or weekend, 7.65. Which is a little bit worrisome that they're really not getting what they need. Sleep onset was 14 minutes. This is WASO, means wake after sleep onset. It was about 13 or 35 minutes, which is a little bit interesting. I'm like, why are they waking up? And again, I think it was because, and again with the number of awakenings, I think it's because of electronics. I think it was because their phone, or they were checking for something. This is a bod pod. This is one of my subjects, actually. So it looks like an egg. There's no sharp edges in it, really. It's kind of, you measure the space without anything in it, and then you put the teen in there, and it does this calculation with her height but in 10 minutes you can get an accurate reading. So they had to make sure they were not claustrophobic, and they had to wear, everything was spandexy. I learned that some of the teens would tap their foot and that would throw off the results, because I can't see this because it closes like an egg. But that's just what you learn as a researcher and you go along. So, again, Seattle, we're not that heavy compared to like an area like Atlanta. So BMI on average is 20.9%, overweight was about 23%. Compared to Atlanta at that time, it was like 40-some%. Insulin resistance, this was what was starting to worry me, and probably another direction my research will go, is that I'm worried a little bit about those who are becoming pre-diabetic. So looking at their fasting insulin and glucose, you can calculate their insulin resistance. And some of them were quite scary, even though their glucose and insulin were fine, the ratio between the two was starting to look pre-diabetic according to the literature. So I'm a little bit worried about that group. Is it because of puberty? Is it because of, it's just, for me, I need to tease that out a little bit more. Is it because they're having some insulin fluctuation because of puberty going on? So I don't know. That's almost 30% though. We're looking pre-diabetic. And some of the literature is talking about the pre-diabetes as something to keep your eye on. So I wanted to just talk about where am I going or what am I doing with all this research, all this data. So last year, Seattle pushed for an earlier school start time. So it was at 7:51 for the high school students on average. Teens and parents were complaining it was too early. We were giving them, like myself, we're giving them data that they are falling asleep in class, they're not getting enough sleep, those kind of things. The American Academy of Pediatrics also came out with a policy paper saying let's try to get the kids to start after 8:30, especially the high schoolers to start after 8:30. So there is a nationwide campaign called Start School Later. You can sign up for the newsletters, but in Seattle, you'll notice if you go back in history, you can see that we did like town hall meetings. We went to the school boards in Seattle. We gave out papers and leaflets and talked at as many community events that we could to try to gain steam or gain popularity in this idea of starting high school students later. Some other cities have done it, but it's a lot of negotiating with bus schedules and after school activities, and parents were like, okay, well then, what are they going to do? If they start later, are they going to be at school till 7 p.m.? What does that mean, that the little kids have to go earlier? What does this mean? All last year we fought for it and it was passed. November 2015, Seattle Public Schools voted 6-1 to adopt a new schedule. So I didn't bring the new schedule, but you can see that all the high schoolers are going to start like later after 8 o'clock, and then the middle school starts, and then backing that up, the elementary school starts earlier, then the middle school, and then high school. So this will be the first time we'll see how, I don't know how it is here in Chester or in Philadelphia. Yeah, so you can look to see, and I probably will be I want to be a part of doing some research to see, pre and post and see how it goes. In other cities, we've noticed that it reduces their irritability. They have less truancy. They do better in classes. Their parents seem to say that they're better students. It's just, we have to see how it goes. So it'll be starting in the fall. So very excited about that. And I was just one of the many researchers who helped with that. And then the translation to metabolic risk. So I am concerned, like I was saying, about the type 2 diabetes, just and how it was affecting adults, and now it's affecting pediatrics, especially adolescents. Many are undiagnosed, and I just want to do I sent in a letter of intent in January for some more diabetes, for like another grant, just to kind of look specifically, maybe, and structure a little bit differently, but to look and see closer if sleep is actually, how is it relating, or how is it specifically altering their insulin and glucose for that age group, and is puberty a part of it? I was going to do like 2 groups one in the middle, in the throes of puberty, and then the older teens, just to kind of see what was going on. And then the translation to bedtime. So remember back to process S and process C, I wanted to look and see if the circadian rhythm had anything to do with this, and I think it does, with the fluctuation of leptin and ghrelin that I was seeing, and see if it relates to diet and physical activity. I'm also leaning, because I remember I showed you that picture of the active graph and how it collected data on light. That light data is really, for me, is interesting. It's hard to conceptualize because you're getting all these minute light. It's just hard to explain, but I'm actually meeting, when I go back to UW, I'm meeting with an engineer to kind of look at the numbers and conceptualize and say, what does this mean? You know, what is it telling me about the blue light? I want to look specifically like the 3 hours before they do go to bed, or even tighter, and look at 1 hour before bed and look to see if that is actually, and then look how they sleep and see if it's some type of association. If you look in the literature, some of the research, a couple articles I did find as of, a week ago, they didn't measure, they only asked the teens sleep, like, on average, how many hours do you sleep? It wasn't measured objectively. And they asked, do you keep your smartphone on? But it wasn't, like, the lux is not measured objectively, so that's why I would like to kind of change it that way. Another idea for a grant is to actually have some teens come into our sleep lab, known texters, and just watch kind of how they do with a PSG, like a sleep test, an overnight sleep test, and just see if their brain waves are kind of, if they ever get into like a REM, how long, is it delayed? Are they having hyperarousals? What's going on? And I would like to look to see if it has anything to do with those who are texting at night. Because we kind of know what teens do without the texting, how they sleep. They sleep really well, but it's that introduction of something electronic. So this summer I'm also setting up some focus groups because I'm interested in interventions. But we have the school start, the schools in Seattle starting later, that might be helpful for them to gain more sleep. But I also want to talk to teens this summer. I'm outlining it, I have some teens already that are interested. I want to know, we live in an age of apps. Everyone has a smartphone. Everyone says, oh, just get an app for that, or we'll make an app to help with this. But when you do talk to teens about if they use the apps, is it helpful? Like, how will you get to sleep? I don't know if we need to ask those teens, what is going to help you get to sleep earlier if you can? What will it be, a text reminder? Will it be an app that you push with like a time, like a counting down clock? I'm not sure, and that's why I need a focus group. So conduct a focus group to kind of see what teens, instead of just giving them an app, ask them and see if they have any suggestions. So that's going to happen this summer, probably late July. So that's exciting as well. So I want to thank you for inviting me to talk. I feel honored that I was here because I was inducted into Eta Beta in 1992. And I've really come a long way, but I'm up for tenure next year. And I just can't, Widener was my stepping stone, my first stepping stone. So I'm just honored. Thank you very much. And then yes.
Hi, Andrea. Congratulations.
Thank you.
Andrea was my clinical student.
Yeah.
Junior or senior for med surg. And excellent. But Mary Rose Smochek and I had gone to a workshop on changing the sleep times for adolescents. Westchester School District here is already, or they're going to implement it. Fairfax County in Virginia
Yes, I heard
has done that, and where was the third one? There was a third one somewhere in the area, but it was really interesting.
Yeah.
Radner was the one who presented the workshop because they were they're doing all of the community education
Grassroots,
things
yeah.
that you.
It's the school board it's the parents, like we did a parent survey, or actually it was a community, but it was geared for the parents. And that was helpful it kind of helped back what we were saying, and because the parents really wanted their students to do well in school. And we had a one sheet that was kind of why this is so important and some statistics, and it was helpful for information. And sign up for that newsletter, Start School Later. It's a newsletter I get like monthly. It talks about like all the other schools that are doing it or trying. Yeah. Thank you.
So in Seattle, did they move the elementary school did they make them earlier? That's
Yeah.
what it should be. I'm in Bucks County, ours is the same way. Our elementary schools are later, and I always say that. When you first started talking, it was the first thing I thought of
Yeah.
that they need.
The large pushback was, but if you think about it, little kids are up early anyway, so we were trying to tell them that your little kids are up that early, let's just get them to school. They were worried about buses, but it's just a matter of flipping it, for the flipping schedule. And then there was some concern about after school and what these kids, if they're starting late, how late are they going to be back, those kind of things. But
Sports, yeah.
with sports, exactly, because they want to start like at lacrosse or soccer, at 3 or 3:30, but now it's going to be pushed a little bit. So.
Yeah, that'll be interesting to see.
Another concern the parents had were that, well, if we're going to start later, they're going to stay up later. They're just going to. So biologically, when they're going through puberty, I didn't really talk about this, but teenagers go through a biological, it's like a shift, where they are not quite ready to fall asleep till like 12 or 1, even though we are going to bed, all the parents are going to bed, we're going to bed, but something that's going through, their development stage where they just have this sleep shift. But the research that we had and that we presented to Seattle was that, listen, they want to sleep, so they won't sleep later. They're not good, even though we're giving them, they have more time in the morning. It's not going to affect them. They didn't go to bed later. They actually went to bed still at that little shifted sleep time. Yeah, and then they slept until 8, which is what they need. We need to get closer to what's recommended because they have, when they sleep, for teenagers, growth hormone is released at night. Cortisol levels, what I've talked about during our presentation, ghrelin levels, leptin, those are all diurnal hormones that go up and down during the night. And the whole thought was that if you're being disruptive or having sleep deprivation, that it alters them. And you want them to have enough sleep so the growth hormone is released every night. Yeah, especially for puberty. Yeah. Any other questions? Thank you.
I want to encourage everyone to sign the sign-in sheet that was on